today. I'm Rachel Avison, clinical psychologist. I worked in congenital cardiology for the last 8 years and then recently joined the neonatal team to work and setting up a service there. I'll make sure I keep to time and then we can everyone get their coffee break. Okay, so the overview of the presentation this afternoon to talk about parents' emotional responses to cardiac diagnosis, both typical and individual, human response to threat and how our brain responds to threat and why we see parents stay in threat mode for quite a long time and what we need to do about that, and what we can do to support and how our support is beneficial to not just the parent but also the infant in thinking about infant mental health as well. So all parents' experiences to emotional distress are unique, and we know that, and everybody responds very differently. There obviously are some commonalities, and we do tend to see tip of the iceberg, these common feelings and experiences. So worry, sadness, anger, self-blame is a really big one, lots of soul-searching, what did I do wrong? But we also do see hope, hopefulness and optimism as well. But I guess through our job, we get to speak to people in a lot more detail, and we can see that there is often a lot more going on than those initial experiences or feelings that we see on the surface level. So there's a really complex interplay of factors that go on underneath the surface of the water, as it were, and they're based on individuals' nature and nurture experiences. So temperament, people have very different temperaments, and that can mean that they cope very differently. Parents' own attachment styles and experiences of being cared for as young infants. Our cognitive ability can influence how we cope with difficulties. Ability to self-soothe and how well parents can do that. Learned behaviours throughout the course of their life. The coping strategies that people develop and their levels of resilience. And then obviously past and current adversity and trauma, which obviously influences how they respond to difficult or distressing news. So strong emotions following a baby's cardiac diagnosis are completely normal and very expected. And so we have a really normalising approach within the psychology and counselling team. This is completely understandable that you feel that way. That's a really normal response to an abnormal set of circumstances with which you find yourself in. A lot of responses, or the majority of responses, are fear-based, and they're driven by our animal brain or our primitive brain. And they're often uncontrollable and very changeable. So I've got the wave in there. Often they come like a wave, and people have sort of expectations that I think they might feel better after a certain number of weeks, so they put time frames on things. And actually what we know is those waves can come and go at very different stages throughout the course of that baby's diagnosis, time on the hospital, and for a long period of time when they get back home as well. Research suggests that emotional responses are not always dependent on the severity of baby's cardiac diagnosis or even their prognosis. So it's something is just worth bearing in mind that I think obviously there's degrees of diagnosis, but parents struggle across a broad spectrum, not dependent on prognosis or diagnosis. So the human response to threat. So we have a limbic system, which is our old brain. It's very primitive and it's based on threat and drive and our ability to escape danger and get out of danger. But that brain is still very much in play when we get difficult news or we feel threatened or we're feeling intimidated by something. So for a lot of our parents, the fear response is easily very triggered. And that's why we see a lot of physiological responses, so aches, pains, distress in their body, and that's the adrenaline and the cortisol making that so impactful for them. The behaviours we often see are sort of fight and flight urges, and that's why we sometimes get parents not visiting the wards. It's just too emotionally overwhelming to come, and that's their flight urge to kind of get, it's too emotional, it's too adrenaline fueled, and they can sort of take off and not engage with what's going on for their baby and work with the medical team. Our new brain has evolved over thousands and thousands of years, but that's our level of insight, theory of mind, our ability to see perspective from other people's views, self-analysis, self-criticism. But what makes that difficult is when our old brain and our new brain interact, and I'll explain that a little bit more on the next slide. But basically we're designed to assume the worst, and that's a survival mechanism to keep us safe and to help with evolution. But what's very, very hard for families is they often experience that threat mode for prolonged periods of time, and it can make them psychologically very unwell. So we've got a tricky brain basically, but we've got old brain and new, and that slide kind of explains it really well. There's a YouTube clip if you want to have a little look at that. It's a really clear breakdown of how our brain has developed and why we do what we do. So basically we're still going on those primitive urges to respond to threat and escape. And our new brain and our old brain interact in such a way that it gets a bit messy and it gets a bit complicated. So it prevents, basically our new brain and our old brain interact in a way that prevents us getting calm. So the new brain starts asking questions like why me, why did this happen, what could I have done differently? And we hear that a lot. It's that sort of soul searching of why do we find ourselves here? But what happens is we get a bit of a feedback loop because the old brain is experiencing threat and it keeps the stress going long after the event. And that's what we're seeing with our families. They're still very highly stressed because their old brain is experiencing the kind of fight and flight, adrenaline, release of cortisol in response to this new thinking and high order thinking. So emotions fall along a psychological continuum. I won't go through all of these, but these are common experiences for parents that we see on the wards following diagnosis, but obviously a long time after that as well. And they range from the healthy, so tearfulness, but being fairly consistent in their mood or behaviour, to some families who unfortunately experience post-traumatic distress and post-traumatic stress symptoms. And they're characterised by hypervigilance and hyperarousal. Again, it's that threat system working, where they feel very highly panicky, anxious, irritable, on edge, and that sometimes and often leads to a lot of anger. And again, we do see a lot of angry parents, and it's often the primitive part of their brain that's responding to the high adrenaline and cortisol in their system. There's lots we can do, which is really, really good news. So for parents who find themselves in the sort of healthy or reacting spectrum, what we really try and do in the early days is to establish what support they can access themselves. So that'd be practical emotional support. So family and friends and community links are kind of best placed to help people who might be struggling with difficult news or difficult experiences. But we're mindful that not everybody has those networks in place. But it's always good to ask the question and just see who's there. And I think we all do as a team. Signposting to written information is really valuable because often parents can go away and digest that in their own time. And in psychological appointments and sessions, people often say, I was given a leaflet, but I didn't read it. And they will come to read it when they feel ready to digest that information. But it's really good that we can give written information or direct people to appropriate websites and information online that they can read in their own time. Peer support is brilliant. That feeling of not being alone and knowing that they're not the only ones in the world dealing with this is really, really helpful. And charities such as the Children's Heart Surgery Fund and Tiny Tickers often offer peer support through Facebook groups, or Tiny Tickers I know offer virtual peer support for families to get together and talk about their babies post-cardiac diagnosis. What we can all do is we can all provide psychological first aid. So obviously it's a fancy way of offering parents space, essentially a safe space to talk and process and think through how they're feeling. Not all parents will take us up on that offer, and that's absolutely fine, and we're respectful of what they need when, but it's knowing that, or parents knowing that we're there to listen and support, and that's the kind of first line of input that we can offer. I'll talk in a bit more detail about that on the next slide. But what I suppose I wanted to highlight is that some parents, unfortunately, for the reasons I explained on the introductory slide with the iceberg, struggle for a long period of time after diagnosis, and actually fall into the injured and ill category. And then it's really important to refer on to specialist services. So now at Leeds, we've got the psychology and counselling team for the cardiac service and also for neonates. And it's a regional service, so expanding the care to families across the region. But it's our job to psychologically assess what's going on for that parent, that individual, or that family. And we're always bearing in mind risk and risks of further mental illness and significant overwhelm and struggle. And in such cases, it's really important to care plan and communicate that with the team about why families are responding the way they are, why they might not be visiting, and what we're doing to help them, I suppose, behind the scenes. We offer intervention sessions, so compassionate focused therapy is the modus operandi of our team, because our ultimate aim is to soothe that tricky brain and the old brain, try and reduce the threat and help people start to work through what's going on for them, what they're thinking and feeling, and the impact of how that's influencing their behaviour, things like visiting, their interactions with their child, which are obviously essential for infant mental health. And in some cases, we do need to refer on as a team, and we're not, best placed to support, I suppose, in terms of community mental health. But we often link in with the crisis team, perinatal mental health teams, ward leads for drug and alcohol addiction, and community mental health services. Just check the time. Okay, a couple of minutes. So what we can all do, this is I suppose, top tips section, but it's notice parental distress. It seems very obvious, of course they're crying, they've just had difficult news, but it's when we notice that distress, we're sort of tapping in. I can see this is really difficult for you, and you're inviting the person to speak. So it's good to ask. It's good to notice the distress and to ask parents rather than assume. I think we all avoid sometimes doing that, and I think that's because it's really, really hard to work through people's difficulties and distress. Sometimes it's not having the time, but sometimes it's not knowing, kind of feeling out of depth and not knowing how to sort of fix. But it's really important that we sit with those people who are struggling and offer empathy, and that's ultimately what it comes down to. There's a bit of a debate between empathy and sympathy. So empathy is seeing what we see in that person and offering support. I can see this is really difficult. It's understandable for you to struggle. Whereas sympathy is kind of back to us. I'm really sorry that you're going through this. I feel really bad for you. That's back to us. So we really try and keep the onus on the family and the parents to build that connection with them. And within that empathy, we can normalise. This is really normal. And again, it's to stop people feeling like they're having a mental breakdown or the only people in the world going through this. But also to validate those feelings. It's normal, it's understandable that you're feeling the way you're feeling. Again, to reduce feelings of self-criticism, self-blame. Again, going back to that complex, tricky brain, that feedback loop that we get where people really beat themselves up about the outcomes of their baby's diagnosis. Yeah, said it before, but no need to fix. It's hard listening and it feels raw, but if we can sit with people and be with them when they're at the most distressed, that's incredibly powerful and can have really long-lasting impacts on the family as well. So the power of emotional support. So for parents, our ability to actively listen and be with them when they're struggling reduces the feeling of threat and the physiological responses. So it can reduce blood pressure and reduce feelings of pain, discomfort in their bodies, tension, and just minimise that threat feeling that can keep things like panic attacks, high anxiety going. We can create emotional safety for them, so a safe place for them to come and talk about how they're feeling, where other people, we hear this anecdotally, but people saying you'll be fine and they're strong, and sometimes it's not reassurance that they need to offload and express their feelings about how overwhelmed they feel about a diagnosis or life with a very seriously ill child. This can foster a real connection with the team and trust building and collaboration. So again, active listening has such power for our ability to teamwork. And it also can boost resilience, help parents find their own ways of coping, which is ultimately what we want, and prevent and minimise further psychological distress further down the line. So we're ultimately trying to stop them going into the red of the ill and injured. And this is about a subtle shift. So we're not hoping to make people feel better or necessarily make them feel happier with the diagnosis or the news that they've been given, but it's a very subtle shift that people feel able to cope with what they've got going on. Just check the time, 2 minutes over, sorry. So this is a conversational tool that can be used if you're finding it really hard to get a conversation going with parents. Some parents just are naturally very quiet or don't disclose very much about how they're feeling and thinking. And we get that in psychology sessions as well. So sometimes we can use this tool to get conversations going and get a bit more insight into what people are thinking and feeling. It's a free resource, so you're welcome to use that in clinics if it's helpful to you. And the power of emotional support for the infants. I've mentioned very briefly about infant mental health, but babies are born with the full range of emotions, which we know, and the importance of attachment can't be underestimated. It's as vital as oxygen to babies. They need an attachment relationship in order to be able to survive and to thrive. And we know that parents who feel connected to their babies and can read cues and respond accordingly can shape their brains. So it has a really powerful impact on helping connections form, and it builds the architecture and the circuitry of babies' brains. So it's essential and it's the foundation of future health. Medical interventions, unfortunately, we know can cause toxic stress. And that can be factors such as the environment, so loud noises and lights on babies, but also the procedures that the babies are having to endure. if toxic stress can be buffered by a really close parental relationship, then that's ideal, because parents are there, they're on the ward, they're responding to their babies, talking to them, speaking to them, holding them if they're able to. But unfortunately, when parents become very overwhelmed or struggle emotionally, they find it sometimes hard to attend the ward, or the environment of the ward is just too threatening. And when parents don't attend the ward, then often we get babies that are experiencing adversity, and there isn't that buffer, that relationship buffer to protect them from toxic stress. And obviously this can have lifelong repercussions, so particularly for babies who are in neonatal intensive care for a long period of time without that attachment relationship and that one-to-one support from a parent, can be really detrimental long term. So emotional regulation is key. So as health professionals, it's our role to regulate the parent, and the parent then to regulate the infant. So we can do that through active listening, support, empathy, compassion, and the parent can then pass this on through to the infant through picking up their cues, soothing the baby, or feeling enough to soothe themselves to be able to soothe their baby, and things like gentle touch, singing, reading. It's all really, really helpful, but it takes a parent that's, I suppose, emotionally well to be able to do that and to engage with that. It's hard, the job that we all do, and sometimes we need emotional regulation, and I suppose it's accessing that through clinical supervision, peer support, things like reflective practice groups, staff support, just corridor conversations, and team working. And this is the last slide. So I just wanted to say, do please get in touch if you would like to know more. I'm mindful I've whistled through that at a really quick rate. But if you have any questions, and there isn't time to speak about it now, do get in touch with the team. So with a cardiac email address and our telephone number. So that's everything.
Brilliant, Rachel. Thank you very much for a really interesting talk. Any questions on the chat for Rachel? I haven't seen any. I just had a quick question. How much do you think the separation of the baby and the parents is an issue for our cardiac babies? I mean, I know we focus in neonates on family integrated care, but does that follow through into PICU and onward on their journey?
Yeah, it can do. It's really detrimental. Babies need to hear parents' voices, and need to be able to see them. I know, sometimes they're in incubators and things, but they do need to be able to see and hear them, and ideally daily. We're really mindful. Obviously, parents have got other commitments outside of hospital life that they do need to, other children and things like that. But if we can get them to be there every single day, it's key. It's crucial. It's crucial for that attachment relationship. So, yeah. Yeah.
Okay, thank you. And then Laura just asked, are the support services available only in English, or is there multilingual support available?
That's a really good question, Laura. We do try and use interpreters, and we've got language line that we use here in Leeds, and we would extend that over the phone if it was for a regional appointment. So yeah, we do. Obviously, the team are English speaking, but we can in any language we can use language line.
Okay, that's really good. Thank you very much. So,
thanks.
And thanks for getting us a little bit more back on time.